Aging Interest Group. We are going to give folks maybe a couple more minutes to join before we go ahead and get started, but we're happy to have you here. Hi, everyone. Great to see you here at this month's webinar for the Statistics and Data Science and Age Statistics. Let me say that again. Statistics and Data Science and Aging Interest Group. I knew I was going to get the prepositions right if I tried it enough. Before we go ahead and get started, as always, we very much like to thank our sponsors for supporting our interest group. Starting with our founding sponsor at the University of Maryland School of Medicine, Claude D. Pepper Older Americans Independence Center, as well as our additional individual sponsors. Also support from the ASA. Now, if you would like to be a sponsor and have a shout out at one of our meetings, we have a QR code here. If you are someone who is not a member of our interest group and somehow you found your way to this webinar, we also would like for you to join us. So as soon as I'm done talking, I will put some links in the chat to give you all the opportunity to join us. It's free. I would like to turn the mic over to our education officer, Anna Capuano. Okay,
Thank you, Michelle. There you go. Wonderful. Thank you, Michelle. I'm very excited to announce a new program from the Statistics and Data Science in Aging Interest Group. And this is the ARISE, the Aging Research Innovations and Statistical Explorations. Go to this QR, it's a registration. If you know of a brilliant data science person developing something novel or working on the dissertation done, and like to present, we are taking now applications. The best 3 works are going to get gold and silver and bronze medals. And the finalists that present in our webinar that is going to start in August this year are going to get a certificate. So please share the word in your departments, okay? Thank you.
Okay, great. Thank you, Anna. I'll just leave that up very briefly as I introduce our speakers. We are pleased to have 2 speakers today. We have Carly Bobek and James O'Malley, who are both from the Department of Biomedical Data Science at Dartmouth University, the Geisel School of Medicine. Their webinar is entitled Gaming the System, Evaluating Spillover in a Video Game Intervention for Advanced Care Planning Using Physician Social Networks. Okay, and I will turn it over to you.
Okay, so thanks very much, Michelle, for that introduction. We're just bringing our slides up. And I first wanted to begin by actually also thanking Teresa Kim. The reason that this seminar actually came about today, you could think of it as a little bit fortuitous, but at the International Conference on Health Policy Statistics in San Diego back in early January, we had a poster presenting our work, and I was there, and Teresa came by and noticed the work and noticed that the grant that's funding the work is one of the grants that she oversees at the National Institute of Aging. And we had a great conversation, and then Teresa followed up and issued the invitation to present to this group. The Aging Interest Group is certainly a close cousin of the Health Policy Statistics section. So yeah, really grateful to be doing this and have been looking forward to our presentation for some time. This work, as mentioned, it's funded by a grant, a PO1 grant from the National Institute of Aging. We have 3 co-authors have all been made important contributions to this work. In very short time, I will actually pass the podium over to my colleague, Carly Boback, who's the first author and leader of this research. And Carly and I, throughout the presentation, will be playing tag team, going back and forward. So this is the outline. There'll be a bit of background of the relevant methodologies. We'll then look at the typical motivation for a step wedge cluster randomized trial before getting into our case study in a little bit more depth and raising or explaining the concern that we had that has actually motivated this innovative methodological research. And then we will conclude. And so I will hand over to Carly.
Great. And so we're going to be talking a lot about social networks and their impact in doing clinical trial research today. And to get us started, I wanted to start with this quote from Martin Luther King Jr., which uses a lot of social network terminology well before that was the thriving field that it is today. And it is that we are all caught in an inescapable network of mutuality, tied into a single garment of destiny. Whatever affects one affects all indirectly. And for those of you who are less familiar with social networks, I'm going to go over just a little brief overview of how they work. And today we're going to be talking about how we represent networks, analyze them, and apply them. And networks provide a really powerful way to model relationships, whether that is in biology, in health services research, social sciences, or machine learning. And so a network consists of nodes, which are these little circles you can see on my screen here, that we can also call vertices, and edges, which we can also call links. And there we go, can create a network, if my mouse wants to work, to connect these nodes. And we can really think of these nodes as being entities, and these can be genes, people, doctors, cities. And edges represent the relationships between them, such as interactions, friendships, or highways. And then a network can be represented mathematically using an adjacency matrix, which you see over on your screen here. This is a square matrix where the rows and columns correspond to nodes, and each entry in the matrix tells us whether or not that edge exists between 2 nodes. And there are a few different ways we can represent the adjacency matrix. So what you see here is a very simple matrix. We can also be really interested in a weighted adjacency matrix, wherein entries represent the strength of connections between nodes. And we can also have directed networks in which our matrix is asymmetrical and one-way relationships can be represented. And so we like to work with networks because they're a really visual representation of meaningful relationships. They also allow us to quantify relationship statistics, such as how many connections does a node have, how central is a node to a network, and how many relationships exist out of all possible relationships. We can use networks to cluster and identify really meaningful communities that impact health data services research. And we can design functions that operate over our networks and in order to derive further meaning from our connections. And so today we're going to be talking about our work, which we call Gaming the System, evaluating spillover in a video game intervention for advanced care planning using physician social networks. Before I dive into this work, I want to start talking about stepped wedge clinical trials, which is a study design that's being increasingly used in public health and medical research to evaluate interventions when a traditional randomized trial may not be feasible. In a stepped wedge trial, clinics or study sites do not all receive the intervention at the same time. Instead, they transition from a control phase in a phased rollout of the intervention. So at the start, all of their clinics are going to be in a control phase, and then at each step, a subset or cluster of clinics are going to transition to an intervention stage, where by the final step, all clinics will have received this intervention. This design allows us to compare outcomes within the sites over time and across sites that are in different phases, which helps us measure the true effect of the intervention while also controlling for time trends. And it is a study design that is increasing in popularity for many different clinical trials, really due to the robust benefits of this design.
All right. So let's talk about some of the benefits of the step wedge design that leads people to adopting them. Well, there's an ethical benefit in the sense that every cluster, so every participant at the cluster level in the trial at some point will receive the intervention. There's logistical issues that often lead one to consider a step wedge trial. It may not be possible to implement an intervention everywhere at one point in time. And so rolling out the intervention across time to one set of sites at a time is often the most feasible way of proceeding. Because of the longitudinal nature of the design and the fact that every cluster eventually receives the intervention, it yields the step wedge design higher power than other cluster randomized trial. And as we'll see, that's a positive, but also a potential con. As noted, clusters act as their own controls. And one of the interesting things, especially from our standpoint, given this work, is that the step wedge trial, as with other cluster randomized trials, is often motivated over a concern about contamination. Contamination is the phenomena where intervention subjects spill over the effect to control subjects. So in other words, one person's intervention, namely one of the intervention clusters, could impact another cluster's and the participants in that cluster's outcome. That's a violation of the Sutva assumption that's well known in causal inference. And then finally, there's a real pragmatic nature to step wedge cluster randomized trial and thus real world relevance. We are in this work going to be really focusing on what we call the contamination resistance motivation for the step wedge cluster randomized trial, because that is an assumption which to our minds is often overlooked. But it's kind of ironical that it's often the real motivation that gets someone to do a step wedge cluster randomized trial in the first place. So when people hear about the word randomization being involved in a study, often they relax and think, well, all problems of bias are going to be taken account of, and we don't need to worry about those. In the step wedge cluster randomized trial, there's certainly randomization, but it's actually at the cluster level, and it concerns the timing of when a given site receives the intervention. In some cases, this actually amounts to not a very large amount of randomization. As I mentioned before, there is the longitudinal nature of the design, and that leads to increased power. And so we urge people generally, before we even get into our specific content of this talk, to just be careful when using these cluster randomized step wedge trials. So to provide further context, let's dive into our case study. This concerns the use of advanced care planning in medicine. So advanced care planning is really a process for helping patients to make future healthcare decisions, recognizing that towards the end of life, a patient may not be then in the most able state to make those decisions for themselves. So the idea is that you have these discussions earlier on in life and express your preferences for what might happen at the end of your life in terms of care. In some sense, the advanced care planning conversation is similar to forming a living will. As often in medicine, like you are encouraged by physicians and others to begin the process very early and then revisit that as you go on through your life and priorities change. And one of the side benefits of advanced care planning is it actually puts a lot of autonomy in the hands of the patients, and that empowerment can actually potentially, and a little bit like a placebo effect, be beneficial. So our study was kind of cool in that it was based around a video game. It was motivated because there was recognized gaps in the amount of advanced care planning conversations going on. And so the purpose of the study was to encourage physicians to engage in more of these advanced care planning conversations with their patients. The intervention was a video game. The physicians who participated received a video game, and the idea and design of the game was such that by playing the game, it would instill into the physician's subjective or conscious state this motivation and incentive to engage in these advanced care planning conversations with their patients. So it was a step wedge cluster randomized trial, meaning that the physicians at a number of hospitals, 35 in total, would receive these video games depending on the point in time at which that the given hospital was scheduled to receive the intervention. The time units in the trial were these 1 month steps, and then we had a longer pre and post period, 3 months each. So the outcome of interest is binary variable of whether or not when encountering when a given patient goes to hospital, they experience one of these advanced care planning conversations. Technically, it was whether an insurance claim was billed for the advanced care planning conversation. Our inferential target is the expected outcome, like whether or not that advanced care planning conversation occurs, if the patient went to a hospital that had already been intervened on versus the counterfactual that they'd shown up and the hospital hadn't been intervened on yet. And we essentially, as I'll explain shortly, evaluate pre-post differences and compare that between the intervention and control groups. So visually, this is a very standard diagram used in step wedge cluster randomized trials. It shows the timing and randomization schedule. And so in our case, the 35 hospitals were randomized to one of these 5 clusters. And this was actually done in a way that balanced the distributions of the hospitals across the clusters. And so if you were in cluster 1, then that hospital had 3 months of patients showing up, and they may receive advanced care planning conversations or not. Then in month 4, the physicians at that hospital received the video game, an actual iPad sent to them in the mail. And they hopefully started playing the video game. And so if patients then showed up, they may or may not receive an advanced care planning conversation, but the physician or at least a subset of the physicians the patients may encounter will have been intervened on. And so the idea is that there's increased probability that they would receive the video game intervention. At the very same time, a hospital in cluster 2 in that 4th month is still in the control state. So their physicians won't have received the video game. And you can think of the square grey box in month 3 and the square green box in month 4 for cluster 1, and the same 2 square boxes for cluster 2 as being emulating a difference in difference study design. And then across each pair of clusters and over adjourning months, you can see that there are 4 other difference in difference type designs that take place. So in a certain sense, the step wedge cluster randomized trial is like a pooled version of multiple difference in difference studies and with the cluster randomization added to it. And so in terms of the statistical model for analyzing a step wedge design, we'll introduce some notation. Y will be the outcome, and this is at the patient level. The subscripts I denote hospital, J denotes patient within hospital, and T denotes time period. And it's important to note that patients are not being followed over time. So at each time period, you can expect different patients to be showing up at a given hospital. You may wish to adjust for patient covariates. They would be in the vector denoted by X, and maybe there are baseline hospital covariates that you want to adjust for. A key variable is this time-varying hospital-level binary variable that indicates whether or not a hospital has received the intervention by time t, and it's 0 otherwise. And so then we might assume some probability model for the outcomes. As mentioned, the outcomes in our case are binary, and so you might be thinking of a logistic regression model. In general, a binary outcome or other outcome that's in the generalized linear models family, a transformation of its expectation is related to a linear predictor involving covariates and possibly random effects. In this case, we had a random effect theta to account for the clustering within hospital. Then, as mentioned, the key variable is this time-varying intervene variable, and that's why its coefficient beta-1 is colored red. We could adjust for patient covariates, baseline hospital covariates, and we adjust for time period. That's the intercept beta with the subscript 0t. So as I mentioned, beta-1 in red is the target parameter. A generalized version of this model would allow beta-1 to change with time. So for example, across the steps of the trial. And I just wanted to make the point of how similar looking that statistical model is to the statistical model used in a difference in difference study, where I still have the time varying intervene variable, although its coefficient is now in red and it's beta-3. But then I have a time invariant variable that indicates whether a given cluster, in this case, hospital or group of hospitals, is in the intervention group. I have a time variable, a binary variable for time that just indicates whether or not you're in the pre versus post time period. And as noted here, the intervene variable, the critical variable in the step wedge cluster randomized trial, is the interaction effect of the intervention group and the post versus pre time period. Difference in difference studies are often used to evaluate the effect of policy interventions. And so, unlike the classic step wedge cluster randomized trials, not every unit actually receives that policy intervention or other intervention. As I noted, well, the difference in difference design can be extended to having multiple time points, so more than just a pre and a post time point. And that kind of embellishment, along with other embellishments, makes it more like the step wedge cluster randomized trial. The key distinctions I would note for the step wedge cluster randomized trial is it does involve cluster level randomization, and all study units end up being intervened on.
So let's dive into some of the initial results from this case study. And what you're seeing here are our published results following that classic setup of a stepped wedge clinical trial. And specifically, our intervention effect is highlighted here, where we can see our effect size was about 0.96 and was insignificant. And this surprised us because other similar studies using a similar intervention was able to find a positive effect, and ours is both non-significant and the effect size is in the negative direction. But simultaneously, we made a couple really important observations about the data in the study. And we started by actually studying the hospitalists who were invited to participate, and specifically how they decided to participate either in a group setting or largely within an entire cluster would decide not to participate at all. And as part of that work, what we'd found was that hospitalists are really, really highly connected. And all of these little hospital groups you were seeing here were all of the hospitalists we were aware of within a hospital. And these are complete networks, meaning that every node is connected to every other node. And this is true whether or not we design these networks such that hospitalists are sharing one patient in a year, all the way through over 1,000 patients in a year. And so this is a really, really collaborative, high-touch group where we hypothesize that by influencing some hospitalists in the group, you are likely to influence many. Simultaneously, we decided to build a hospital level network wherein our nodes in this case are actually going to be hospitals, and they're going to be connected if the hospital was sharing a hospitalist. You're going to see square nodes, and those are going to be trial hospitals where they participated in our study, and circular nodes are going to be non-trial hospitals. And then color is going to represent that there were any participating physicians in that hospital, and it'll show blue if there were no participating physicians. And what I hope you can immediately see here is that our hospitals are really connected. And this indicates that they are sharing physicians really frequently. And we can automatically see here that we have a lot of circular nodes, which are orange, indicating that we had hospitalists who received the intervention who were working at non-trial hospitals. We then decided to investigate, okay, well, how many of our patient encounters then saw a hospitalist that was intervened on in the wrong step given what hospital that patient was at. And we found that 5% of our patient interactions had that direct contamination right away of they saw a hospitalist who was intervened at a prior step to where our patient was actually assigned based on which hospital they were at. And so how would a spillover then lead to cluster contamination? We've seen this very direct effect of, okay, they were seen by a physician who was intervened at the wrong step. And so there's that individual behavior change we could see happen. Physicians are going to be influenced by the intervention. They're going to increase their ACP conversations independently, and they could be working at a non-intervened upon practice. But we know that these hospitalists are really highly connected and they have team-based care dynamics. And so you're going to have intervention-exposed physicians who can delegate advanced care planning facilitation during patient handoffs, and this will influence colleagues. There's also observational learning that could be occurring where physicians may subconsciously adopt behaviors after seeing peers engage in advanced care planning conversations more frequently. And then there's also just peer influence and socialization. Physicians could be actually having discussions about this intervention or playing the video game in the break room. And that could lead to having a lot of conversation about ACP facilitation among colleagues that would really reinforce behavior change when we don't have guaranteed independence across our hospital units.
All right, so let's just suppose for a moment that we were able to measure a network between the physicians participating in this study that captured the net sum of all of those factors and perhaps other factors that lead physicians to influence one another. And so here I've just got the 7 physicians with alphabetic letters, and in a binary valued network, we would just have ones or zeros indicating the presence or absence of an edge between the physicians. And in a general case, the relationships could be directed. So a certain physician, like physician A, might say, I have a professional relationship with physician B, but they don't say that for physician E, even though physician E says that they do have a professional relationship with physician A. In our particular case, we actually ended up measuring an undirected network. And so the relationship in both directions is the same. But what I'm illustrating on this slide applies equally. And so if you did measure a network like this, then you could ask the question, well, what's the potential for one physician to be influenced by other physicians? And you might reason, well, I think the physicians who could influence a given physicians are those to which that physician has edges going outwards to those physicians. So in the case of physician A, they have an edge to physician B and an edge to physician C. And then you might, unless you had additional information, just reason that you feel that physician A would be equally influenced by physicians B and C. In the case of physician B, there's only one physician, namely physician F, to which they have an edge, and so they would be solely influenced, if they're influenced at all, by that physician F. And then if you had a behavioral variable, in this case, it's going to be the intervention status of the physicians. You can put each physician's behavior or phenotype or intervention status into a vector, and you can multiply it by the scaled adjacency matrix that I've denoted by W to yield for each physician the average value of that behavior in the physicians to which they have that professional connection. And in general, you could measure this variable just at baseline. You could also measure it separately at distinct periods in time. So as mentioned, the phys intervene variable, it's a vector with ones and zeros, with a 1 indicating that the physician corresponding to that row has been intervened on by that time, and 0 otherwise. And in the step wedge trial, if it all goes to plan, then phys intervene begins with all values equal to 0 at time 0 and ends up as a vector of 1s at the end of the study. W, it could be measured at baseline, in which case it's just the status of the professional network between the physicians prior to the study beginning. You can also measure it if you have the right data at each time point in the study. The scaling of the rows to make them sum to 1 is it guarantees that the resulting values are essentially weighted averages. So for a given physician, you are potentially influenced by the weighted average of your peer physician's behavior. That's just an assumption that we would compute that. We could also keep things in terms of totals. And when patients come into the hospitals in our study, they may see 1 or more physicians. And for measuring the potential for spillover or contamination, in that case, we could just take the average of these exposure variables. So I initially was just assuming that their network magically was measured. In general, unfortunately, it won't be measured, and you'll have the additional challenge of thinking about measuring it. And I would say the biggest challenge in all of social network analysis is the measurement of the network. In our case, because physicians were intricately involved in terms of the study and were linked to the units of intervention, namely the hospitals, then, and because we had access to claims data through the group that we worked with, we're actually able to measure networks between physicians based on their co-occurrence on the same insurance claim bill that was generated by a patient during their hospital stay. And across all the patients that participated in the study, we can evaluate weighted edges between these physicians. Or alternatively, if we were designing a study and had a baseline period of time, we could evaluate a network at baseline using such claims data. And as Carly mentioned, the physicians tended to move around the hospitals a little bit, and so our edges were both within hospital and across hospitals. The within hospital edges is what we would worry about traditionally when thinking about a step wedge cluster randomized trial, and would lead us to, instead of having physician level randomization, to actually have hospital level randomization. The inter-hospital edges, those are, if you like, the unexpected ones, the ones that in a traditional step wedge cluster randomized trial we would hope would not exist. However, as Carly described and has depicted here, such edges did exist. In some cases, they were contained within hospitals, and so this dashed circle depicts such a hospital where there was no physician sharing, if you like, across hospitals. But in this other case here, there's at least 3 hospitals that are connected, and you can see how the nodes, the physicians, are color-coded by the step of the trial at which the hospital they were attributed to received the intervention. And to just reinforce the potential for spillover effects or contamination, what you just saw was a video across the 5 steps of the trial of the extent to which of the intervention being rolled out. Those were the dark green nodes, and then the light green nodes were the neighbors of the intervened on subjects. And you would have noted just how quickly the network of study physicians who participate in the study went from a lot of white nodes to a lot of colored nodes. We're going to go through this a little bit more slowly now. The dark green, as I mentioned, is the intervention receivers. The light green now is the first degree neighbors, and the yellow are the second degree neighbors. So this is in step 1. This is where the first group of hospitals and the physicians who participated in the study within those hospitals have received the intervention. They're the dark green nodes. All the other physicians at the same hospital are automatically the light green nodes, as well as some physicians at other hospitals. Remember those inter-hospital connections. And then the yellow nodes are those physicians who are the peers of the first degree neighbors. And so you can see at wave 1 or step 1 of the study, a large proportion of the network is already colored. Here's step 2. And by step 3, it's almost the case that every physician who participated in the study has potentially had some access to the intervention through either their being directly intervened on, their first degree neighbors, or their second degree neighbors. And so what we are doing, or what we are going to describe next, is how we use this network that we were able to measure to both construct a test for contamination and a way of overcoming it under statistical modeling assumptions. And so to just remind you and to introduce some notation, W is that adjacency matrix representing the network in which each row is scaled to sum to 1. And in our case, we did update it each wave of the study. Phys intervened is the vector which tells you whether a given physician has received an intervention as a function of time. The exposure variable as a function of time is the product of W or W subscript T multiplied by phys intervened. And so that yields the proportion of a given physician's peers who have been intervened on by a given study wave. And then the exposed variable subscripted also by J and T is just picking out the exposure status of the given physician that a patient encountered during their stay. And if they encountered multiple such physicians, we took the average of that variable. And then once we did that, we went back to our statistical model for analyzing the step wedge cluster randomized trial and added some terms to it. What I'm showing at this point is the exact same model shown previously for the particular case of a logistic regression. So remember, the intervened on variable is our key variable, and its parameter beta 1 is our target of interest. We adjust for patient covariates, and we may, in general, adjust for baseline hospital covariates, and we adjust for time trends. So the outcome, remember, that's a binary variable indicating whether or not the advanced care planning conversation occurred at least once during a patient's hospital stay, and the expected value of that is the probability of that occurring. As I mentioned, the intervened variable is our key variable. We may adjust, and we did adjust for some patient level covariates, and our intercept parameter with the subscript T accounts for time trends across the study steps. Finally, as I mentioned before, there's the hospital random effect to account for the clustered nature of the data. And here are the 2 additional terms. First of all, our exposure variable, or this computed physician intervened variable, that is evaluating the direct effect of spillover on a patient's outcome, and then the interaction term between the intervened on status of a hospital at a given time and the extent to which a patient entering a hospital after it had been intervened on encountered physicians who were exposed to other intervened on physicians. And so to just remind you, here's the adjacency matrix W multiplied by this phys intervened variable that yields the spillover term, and then there's the interaction of the spillover and the intervened on variable. And so I'm just rewriting the model here, and I'm going to talk through it a little bit further. Our target has generalized from just being the beta 1 parameter, the effect of being intervened on at a given function in time, to also that plus the spillover effect of the physicians the patient encountered prior to a hospital being intervened on, already having been exposed to other physicians who were already had received the intervention, and the interaction of that with the given hospital's intervention status. So our total effect of the intervention now involves 3 unknown parameters. An interesting test we might conduct is whether or not the interaction term is significant, because if it is, that would tell us that the effect of contamination significantly changed the effect of the intervention variable. And we could also do a test of statistical equivalence there. The beta 1 term now has a very interesting interpretation. So you might be thinking back to your first year statistics class and a recipe or a piece of advice you were told back then, which is don't try and interpret the effect of a main effect when you have an interaction effect in the model. And so the intervene variable is such a variable. You have its interaction with the exposure or spillover variable. However, if we were in a case where there was no spillover, so expose equaled 0, then the other 2 terms would fall out of this model and would be left with just the intervene term. But now you see how the interpretation of beta 1 has changed to being the effect of the intervention in a counterfactual world in which there was no contamination. So in this sense, we're recovering the effect of the intervention that we initially were wanting to estimate. As mentioned before, beta 2 is the effect of a patient encountering physicians who have been exposed to already intervened on physicians. And that can be thought of as the effect of the intervention on the untreated, because it applies to the pre-intervention time period for a given hospital. And beta 3 is the interaction term between the spillover variable and the intervention status of a hospital. And I'll just note that when you use W versus using W subscript T, the interpretation of beta 2 and beta 3 change a little bit. And that's just because when you use W subscript T, you are implicitly assuming that the intervention has not actually led to an alteration of the network. If it did do that, then the interpretation would be substantially more complicated.
And so we're going to quickly fly through some of the results of this particular case study, and then try to leave lots of time for questions. And so you'll recall that this was the intervention effect that was available before we measured spillover and this intervention by spillover interaction term. In a model which measures both of these, we can now see that our intervention effect, while insignificant, is now in the positive direction, which does align with the literature and what we expect. The spillover effect is actually quite large and does indicate that as physicians are interacting with other physicians who received the intervention, they are far more likely to deliver this advanced care planning conversation. If we dive into this interaction term, we'll notice that it is also quite significant and in the negative direction, and that is really accounting for where we're seeing this flip from having a negative, insignificant effect towards suddenly looking like our intervention may have had a positive effect, in that when there was more spillover present, it was much harder for us to detect the intervention effect. We also expanded this out to consider how the intervention would interact with different steps of the trial, really noting that we kind of saw this potential burnout of places where the spillover could have a positive impact through about step 3. And so you'll see here that when we do this, we actually see that our intervention is borderline significant and positive. Our spillover effect is still very large and highly significant. That interaction terms, very similar to what we saw before, is in the negative direction and significant. And of course, when we get all the way there to step 4, we see like a highly significant interaction with this step 4, indicating that there was a real dampening of that intervention in that step. And there's a lot of reasons why that could be. One is this hypothesized burnout we saw of the available spillover in the network. It is also worth noting, and I'm sure many of you noticed this, that this trial ran throughout COVID, where there was many peaks and waves of the pandemic. And that step 4 really does sort of indicate a place just after a massive COVID peak. And we suspect that there may be some unmeasured variables related to the pandemic, which influenced that particular step of the trial. And so an important question would be, well, are other trials at risk of similar social contamination? And we think, yes, that could be true. This is particularly true in any highly connected settings where we have closely connected participants, which could be healthcare, educational institutions, et cetera, could be susceptible to this kind of contamination. We think this is particularly true for interventions with a behavioral component. If they can be influenced by social behaviors, interactions can inadvertently spread through a professional or social network, and very true in any dense professional network setting. And if you happen to know of any trials in any of these settings, we would love to talk to you to see if possibly this method could help illuminate how this trial is operating in terms of social connections. And so we have a variety of conclusions. One is that stepwise cluster randomized trials are really commonly used. When intervened on units have professional or social ties across hospitals, there is a risk of contamination. Example units that may transmit contamination are physicians who change hospital affiliation, physicians who work at multiple hospitals, or physicians who share patient care across hospitals. And that we can test for and mitigate the effects of this contamination by measuring network with intervention units as nodes. This is easy to do with administrative claims or EMR data as a really sort of feasible way of measuring these networks. And if a network is known at baseline, we could actually use this in study design to try to prevent some of this contamination. And very briefly, we have next steps, one of which is creating an R package that will help create networks and calculate these variables for researchers to use without needing to develop a deep expertise in social network construction. We are seeking additional case studies to evaluate spillover impact. And we are leaning on some prior work we did to design simulation studies that can quantify the impact of these misrepresentative results under various assumptions. I'm going to throw some references up on the board, and we would love to answer some questions at this point.
Great. Thank you so much, Carly and James, for such a wonderful presentation. Let's see, we have some questions in the Q&A. Folks, if you have additional questions, just drop them in there. Let's see. First question is from an anonymous attendee who says, did you consider the cluster hospital only a term in its own or with an interaction with time? And did you happen to get ICCs to determine how much variation existed?
Michelle, I'm not sure if we fully heard the whole question, so I'll repeat back what I thought I heard you say, that did we account for the level of clustering changing with time? And so that would be the level of patients within hospital, that ICC changing with time?
Yeah, they were specifically asking if you included an interaction with time, and did you get interclass correlations to determine how much variation existed?
Yeah, so the only interaction with time was just in the second set of extended results that Carly showed, where we allow the intervention effect to have changed across the steps of the trial. And that was in addition to the interaction with the exposure to already intervened on peer physicians. But we didn't do anything with the random effect part of the model in terms of interaction with time, like a random slope.
Got it. So Teresa has a question, and this relates to the practicality of being able to estimate that adjacency matrix.
Mm-hmm.
She's wondering if was this Medicare fee-for-service only data, or did this population consider Medicare fee-for-service and Medicare Advantage? So that's the first question. I'll let you answer that one first.
Yeah, and this actually isn't using Medicare data. This was using billing data that was supplied to us directly from our physician partners, which allowed us to estimate this network sooner than we were able to access Medicare data. However, you could use Medicare fee-for-service and Medicare Advantage data both to construct very, very similar networks. And we've done that in other settings.
Yeah, and it is the case that the PO1 has used this CMS Medicare data, and that was using the on-premises data with the approximately 2-year time lag that Carly spoke about. And so that the claims data we had were virtually identical in form to actual CMS claims, but they were just the claims that were retained by the company, this physician supply company, as their own internal records that then got submitted for reimbursement.
Got it. So Teresa made the point that, by chance did the Medicare fee for service, even though it wasn't used in this case, have patients who are foregoing Part B because advanced care planning is reimbursed by Medicare Part B. And she mentioned your PO1 having a DUA for CMS, which may explain why some reasons that some do not engage in advanced care planning specifically because they do not get reimbursed. And so that reimbursement issue, did that come into play at all with any of the data that you had?
I would doubt it because this company, the reason why we ended up having this partnership with them is they were very motivated themselves to have their physicians be more engaged in advanced care planning conversations. So I don't think any of the physicians who enrolled in the trial would have been of the mindset that they were absolutely not going to do this. However, one of the things we've heard about is, I guess it's kind of related to the upcoding phenomena that if in a given encounter with a patient, there was something else that was diagnosed or done in terms of a service that was more profitable than the reimbursement for the advanced care planning conversation, then it could have been the case that the conversation truly did exist, but that it just didn't show up on the bill. And so that was one of the initial concerns, especially when we had done that initial analysis, which was just the standard step wedge analysis, and before we looked into the contamination issue.
Got it. Thank you. So Charlie Hall has a question. He's asking, can you comment on the ethical issues involved in cluster randomized trials stemming from the impossibility of obtaining individual informed consent from patients? He's the vice chair of his IRB, and this question has come up for them.
Yeah, well, I don't think I'm the best person, and maybe Carly.
Yeah, I can tell you, I have overheard conversations along the same lines. Within Dartmouth, we have a hospital and a medical center too, and it's worth noting that we have an opt-in rule for patients to opt in for research, and there are other research centers around the country which have an opt-out. And you sort of see this like perfect inverse of it's very few people who choose to opt, whether it be in or out. And so that really limits our access to patients at Dartmouth, although we're a lot more confident that those who opt in are doing so with informed consent and are comfortable. And so I know that this is a major conversation. I know that our IRB talks about it a lot. I know it comes up a lot when we're trying to create systems and tools that make it easier to do medical research on campus. But I don't know what the right answer is. There are varying lines of thought there. Would love to follow up and hear what your lines of thought are and potentially connect you to our groups who discuss this. But internal to Dartmouth, we rely on opt-in, which is also imperfect because it doesn't outline specific research, just research in general.
Thank you. When you were saying that, it kind of reminds me of those behavioral economics experiments about people just generally are more likely to choose the defaults.
Yes, exactly.
Okay, and so Charlie's saying he would love to talk later as well. Let's see, we have a question about, will the recording be shared? It will. It will be on our website as soon as it's processed. If folks have more questions, you're welcome to drop those into the chat. Let's see, I guess while we're waiting for other folks to drop their questions, I had a couple as well. So in terms of some of the rationale that was made about why one would choose the step wedge design, it was pointed out that this tends to be a particularly powerful study design. And so I was wondering if there are particular use cases where it could be beneficial in terms of being resource efficient, and what are the circumstances that would enhance its resource efficiency versus other randomized trial designs.
Yeah, so I think often when you have interventions that may be of an educational nature, and so you could imagine a team of educators, the step wedge cluster randomized trial is a lot more resource efficient because you need many fewer educators than if you were doing the educating everywhere all at once, because people just can't simply be everywhere at once. So I'm assuming like this is some kind of in-person type training or intervention, not an online type of intervention. Yeah, so that would be one.
Great, thank you. I also had another question where, where you were differentiating between receiving the intervention because it was your turn to receive the intervention versus being exposed because of a spillover. That reminded me of, some of the work in causal inference about treatment non-adherence. And so I'm wondering what kind of analogy can be drawn there, and can we tap into some of that methodology as well to inform some of the approaches here from a counterfactual framework?
Yeah, like that is a great question. I would say in a sense, the spillover phenomena is almost the opposite type of phenomena to non-adherence. So often non-adherence is the situation where you got randomized to something that meant you were meant to be taking a medication or doing something, practicing something, and you didn't do it. So this would be a little bit like the reverse of that, to the situation where in some studies it might be possible for the control group to get access to the intervention group treatment. And so what is happening here is, I would say, a little bit in between that, in that it's an indirect version of the intervention that the physicians early on that are still in the control phase might be receiving through these ad hoc conversations or by reading shared notes about a patient that they are treating along with someone else, another physician who's already been intervened on. So I think, yeah, that is, yeah, Michelle, a very accurate and astute comment. Where there's a big distinction is the way of overcoming that concern. And so you have the causal inference methods that deal with non-compliance, and you might be familiar with the never taken, always taken type of language. And in a sense, the methods that are used there are a little bit like instrumental variable type methods. You tend to make an assumption about the actual being just your randomization status becoming or not directly impacting the outcome once you condition on treatment received. In our case, as articulated with the spillover type of problem, then our way of identifying the extent to which you are at risk of being in a physician who is an untreated physician who experiences the intervention is through the network. And so we have to, you could sort of think about, in many cases, maybe the network is an unmeasured variable, and there's a form of non-compliance or confounding associated with that. But if we are able to measure the network, then we can both test for that particular version of the violation of the spillover effect or lack of spillover effect assumption, and as we described, overcome it.
Right, and having a very practical way to measure that adjacency matrix.
Yeah.
So thank you. I figured that there had to be some connection, but I couldn't think of what it was. Okay, so according to my clock, it is 2 p.m. Eastern. So I want to respect folks' time and to thank you again for attending this presentation, and also to thank our speakers, James O'Malley and Carly Bobeck. Thank you so much.
Thank you for having us.